Hi guys, today we'll discuss the topic of acute pancreatitis. First, we'll start with the pancreatic anatomy. This is the superior mesenteric vein. The part of the pancreas which is anterior to it is the neck of the pancreas. The part which is posterior to it is the uncinate process of the pancreas. The part which is medial to it is the head of the pancreas. The part which is lateral to it is the body of the pancreas. Now, we draw a line along the lateral border of the vertebral body or the lateral border of the aorta. The part which is distal to it is the tail of the pancreas. Now we are done with the anatomy of the pancreas. Now we'll move forward to look at the diagnostic criteria of acute pancreatitis. Acute pancreatitis is diagnosed using 2 out of 3 criteria. What do we mean by this? That is, out of these 3 conditions, even if 2 conditions are met, we can call it an acute pancreatitis. So, the first one being epigastric pain, which is radiating to the back. Next, increase in serum amylase lipase more than 3 times the normal. It has to be more than 3 times its normal. And then characteristic imaging findings either on ultrasound, CT or MRI. So, even if ultrasound, CT, MRI are negative for pancreatitis, we can still call it an acute pancreatitis based on serum amylase and lipase and the clinical history, right? Now we'll move forward to look at the etiology of acute pancreatitis. The most common etiology being the gallstones and alcohol. However, if it is a child which is coming to you with acute pancreatitis, always do an MRI with an MRCP to rule out anatomical variations of pancreas such as pancreatic divisum, annular pancreas, and abnormal pancreatico-biliary junction. However, if it is an adult who is over 40 years coming to you with acute pancreatitis, always do a contrast enhanced CT to rule out pancreatic ductal adenocarcinoma, right? These 2 conditions are very important. That is a child coming to you with acute pancreatitis and an elderly person coming to you with acute pancreatitis. Always you need to look for the etiology of pancreatitis in these 2 conditions, right? Now we'll move forward to the various indices which are available to assess acute pancreatitis. They are 2 in number. That is, basically we have a prognostic index and a severity index. Among the prognostic indices, we have Ramsden score, Apache score, and BISAP score. This is important for a clinician perspective. For a radiologist, we'll look at the severity indices. We have radiological indices, that is modified CT severity index score, and among the clinical indices we have modified Atlanta classification and we have modified Marshall score which assesses organ failure. Now we'll look at this modified Atlanta classification in detail. Modified Atlanta classification classifies acute pancreatitis based in 3 headings. The first one, based on the duration, it divides into early as well as late pancreatitis. Early pancreatitis is within 1 week of symptoms. Late pancreatitis is after 1 week of symptoms. Based on the severity, it divides into mild, moderate, and severe. Mild does not have any organ failure. Moderate presents to you with organ failure which is less than 48 hours. Severe will have organ failure for more than 48 hours. And finally, which is the most important for the radiologist, is that it divides acute pancreatitis into acute interstitial edematous pancreatitis and acute necrotizing pancreatitis. Now we'll see these 2 conditions with an example. First one is acute interstitial edematous pancreatitis, that is AIEP. This is characterized by a bulky pancreas which shows heterogeneous enhancement on post-contrast. And how do you know it's bulky? Bulky pancreas is that pancreas which is more than 3 centimeters at the head, more than 2 centimeters at the tail. So this is very important, the values, that it is more than 2 centimeters at the tail, more than 3 centimeters at the head. Now we look at an example. So we can see in this case scenario where the tail is bulky, you can see there is some amount of peripancreatic fat stranding. However, there is no area of necrosis, there is no non-enhancing areas within the pancreas. So this is a typical example of acute interstitial edematous pancreatitis. Now we look at the MRI of the same. this is a T1 weighted sequence where we can see that in the tail of the pancreas, there is loss of fat. So loss of fat on a T1 sequence is the most sensitive sequence to pick up pancreatitis, I mean acute pancreatitis. So even if the ultrasound is negative, CT is not showing features of pancreatitis, if clinically the suspicion of pancreatitis is very high, always go ahead and do a MRI, in that the T1 is the most important sequence. You see the loss of fat on a T1 sequence, you can call it an acute pancreatitis. Now we'll go to the next thing, that is acute necrotizing pancreatitis. Acute necrotizing pancreatitis is defined as a presence of a non-enhancing necrotic area within the pancreas or in the peripancreatic region or both, that is including both pancreas and peripancreatic region. Now we look at an example. So we can see that in this example, the entire pancreas as well as peripancreatic region is replaced by a necrotic collection with a foci of air within. So this is a typical example of acute necrotizing pancreatitis. Now we look at modified CT severity index score. So modified CT severity index score, the difference between the original CT severity index score is that it adds extra pancreatic collection, and presence of any of the extra pancreatic collections like ascites, pleural effusion or a vascular complication, it gives a score of 2, right? And for a total score of 0 to 2 we call it a mild, for a total score of 4 to 6 we call it moderate, and between 8 to 10 we call it a severe pancreatitis. And this is very important for a radiologist because every case of pancreatitis you have to give a modified CT severity index score, right? Now we'll look at the pathogenesis of acute pancreatitis with its complications. So we already know acute pancreatitis is nothing but an inflammation of the pancreas. Once there is inflammation of the pancreas, there will be release of pancreatic enzymes into the surroundings. These pancreatic enzymes will create inflammation of the surrounding structures, which leads to saponification of fat, cytokine surge, and proteolytic damage of the surrounding vessels as well as the organs, right? Because of this cytokine surge, there is excessive inflammatory response which is occurring in the body, which leads to various systemic complications. The systemic complications include inflammation. Inflammation will cause vasodilation. Vasodilation will lead to release of fluid from the vessel into the third space, causing ascites, pleural effusion, which will lead to hypovolemia. Once there is hypovolemia, there is reduced oxygenation to the tissues. Because there is reduced oxygenation to the tissues, patient will go into shock. Once there is shock, the complications of shock will be like metabolic encephalopathy. To the renal, you'll have renal dysfunction, and to the heart, you'll have cardiogenic shock. And then the other complications being systemic inflammatory response syndrome, multi-organ dysfunction syndrome, acute respiratory distress syndrome, hypokalemia, and paralytic ALS. These are systemic complications. What is important to radiologist is the vascular as well as the local complications. Vascular complications, whenever you're suspecting, that is, in the history they'll tell you, there is a GI bleed to the patient, there is drop in hemoglobin by more than 2 grams per deciliter, or there is blood in the drain. So whenever this history is available, always do a dual phase CT with an early arterial phase and a venous phase. Why is this important? We'll see now. Basically, vascular complications are 2 in number. We have arterial complications, we have venous complications. Arterial complications, we can either have a pseudoaneurysm or contrast exacerbation. The most commonly asked question in most of our vivas is, how do you differentiate between a pseudoaneurysm and a contrast exacerbation? This is the perfect answer. We look at the size and shape of the lesion. Pseudoaneurysm is typically round in shape, and on an arterial phase and a venous phase, whenever you take, the size remains same on both phases, right? In contrary to contrast exacerbation, the shape of the contrast exacerbation is irregular, and from arterial to venous phase, contrast exacerbation will show an increase in size. We'll look at it with an example. So these are the 2 examples where we can see in the first case that this is a rounded lesion, right? So this is most likely a pseudoaneurysm, and here you can see that the lesion is very irregular. So this is a contrast extravasation. Now the second criteria is that we look at the density of contrast. So, if the density of the contrast is matching that of a blood pool and the density remains same on both arterial and venous phase, then it is a pseudoaneurysm, right? Secondly, coming to contrast exacerbation. If the density from arterial to venous phase is either increasing or decreasing, then it is a contrast exacerbation. Do not get confused, guys. Basically, you'll have two phases, arterial and venous. Look at the HU of the lesion. If the HU of the lesion is same between arterial and venous phase, it's a pseudoaneurysm. If there is difference in the HU from arterial to venous phase, then think of a contrast extravasation, right? Now we'll go to the venous complications. Most common venous complication is venous thrombosis. It is most commonly seen in a splenic vein more than portal vein, more than superior mesenteric vein. However, in an extensive severe pancreatitis, you can even have pulmonary embolism. So we'll look at an example. So we can see in this example that there is a filling defect, non-enhancing in the splenic vein, which is suggestive of a splenic vein thrombosis. In an acute scenario, you'll see that there is dilation of a splenic vein with a non-enhancing filling defect. However, in chronic thrombosis, there might be non-visualization of the splenic vein, which is replaced by multiple collaterals, right? Now we'll come to the last major topic, that is local complications. Local complications are predominantly 4 in number. That is acute peripancreatic fluid collection, pancreatic pseudocyst, acute necrotic collection, and Waldorf necrosis. Acute peripancreatic fluid collection and pancreatic pseudocyst are a sequelae of acute interstitial edematous pancreatitis. Acute interstitial edematous pancreatitis most often shows spontaneous regression. However, in few cases, it can progress to acute peripancreatic fluid collection and a pancreatic pseudocyst. However, acute necrotic collection and Waldorf necrosis are a sequelae of acute necrotizing pancreatitis. First, we'll read about acute peripancreatic fluid collection. Acute peripancreatic fluid collection is typically seen less than 4 weeks. It is non-encapsulated. It does not have an enhancing necrotic component. We'll look at a case scenario now where we can see that there is this focal area in the lesser sac, tail of the pancreas, which is showing fluid attenuation without any encapsulation, right? And if you measure the HU, you'll have a HU typically less than 20, which says that it is a fluid attenuation. So, in such cases where you are seeing an acute peripancreatic fluid collection, what should you do? Just wait and watch. It will show spontaneous regression most of the times. In few cases, it can progress to a pancreatic pseudocyst. Now we'll read about pancreatic pseudocyst. Pancreatic pseudocyst, we typically give this term when the duration of symptoms are more than 4 weeks. Pancreatic pseudocyst is an encapsulated lesion. It does not have an enhancing necrotic component. Coming to the case scenario. So in this case, we can see that there is a fluid attenuating collection which is encapsulated, and this fluid will have a HU less than 20. We can confirm this on MR where we can see that there is a T2 intensely bright lesion which is similar to that of a fluid signal. However, there are no T2 hypointense contents within the collection, right? So this is a typical example of a pancreatic pseudocyst. Now, how do we treat a pancreatic pseudocyst? If it is a patient coming to you with a pancreatic pseudocyst and the patient is completely asymptomatic, you can still wait and watch for some time. But however, the pseudocyst is continuing to increase in size, or the pseudocyst is causing obstructive symptoms because of the pressure effect on the CBD or on the ureter, then you need to start the treatment. So how do we start a treatment? This is a recent update that we do something called as LAMS. LAMS. What do we mean by this is lumen opposing metal stent. How do we do this? Basically, we put an endoscope, and via the endoscope, we put this metallic stent between the stomach and the pseudocyst, right? Between these two things, we put a stent and come out, and we call it lumen opposing metal stents. However, if this fails to drain, then we go to something called as transgastric stenting. So what is transgastric stenting? Again, we put an endoscope and then we create a fistula between the wall of the pseudocyst and the stomach, and we put these pigtails. Right? This is transgastric stenting. However, if this also fails, we go to a surgical procedure, that is a cystogastrostomy, where we create a opening in the wall of the stomach and we connect it to the wall of the pseudocyst. So this is typically a cystogastrostomy. So this is the final thing what we do for a pseudocyst. However, if it is an infected pseudocyst, we treat it similar to a walled off necrosis. Now we are done with the pseudocyst. We'll go to the necrotic collections. Starting with the acute necrotic collection. Acute necrotic collection is a term given less than 4 weeks. It is non-encapsulated, but however, you will have non-enhancing necrotic components within it. Looking at the case scenario, we can see that the pancreas is bulky with peripancreatic fat standing. However, in the center, you can see a area which is showing non-enhancement. This is suggestive of a acute necrotic collection. So how do you treat it? You can wait and watch if the patient is showing clinical improvement. However, if the patient is worsening, you have to do CT or an ultrasound guided percutaneous drainage. Coming to our last complication of local, that is walled off necrosis. Walled off necrosis, typically we use the term more than 4 weeks. It is encapsulated. It will have a necrotic component. We'll look at a case scenario where we can see that there is a thick wall, well-defined collection which is located in the gastrohepatic region, and if you measure the HU of this fluid, you'll have a HU more than 30, right? So this is why I tell this is a necrotic collection. We can look at an MR where you can see it's a well-defined collection with T2 hypointense areas within, and these necrotic components will show diffusion restriction also, calling it a walled off necrosis. However, if you're seeing a necrotic collection with few air foci within, then you can call it an infected necrotic collection, right? It is important to mention in your reports that is it a necrotic collection, is it a pseudocyst, because the management will vary accordingly, and we are looking at the management of walled off necrosis now. Once you see a walled off necrosis, you have to mention the clinician that if there is a transgastric window, what do we mean by it? Is there a close proximity between the collection and the stomach? If it is there, that is, if a transgastric window is present, we'll treat it similar to a pseudocyst. You can go ahead with a LAMS. If that fails, we can do a transgastric stenting. If that also fails, instead of doing a cystogastrostomy, we do here something called as endoscopic necrosectomy. If that also fails, we do a surgical necrosectomy. However, if there is no transgastric window, then what will we do? We do an ultrasound or a CT guided percutaneous drainage. How are we doing this? We'll just read it in few minutes, right? If this fails, you have to upgrade the size of the pigtail starting from 12 French, and you can go up to 24 French. Even with 24 French, you are not able to drain the collection. Then you again end up in a surgical necrosectomy, right? Now we'll see few miscellaneous local complications. These are very important to be learnt, to be written in your reports, and they're repeated spotters as well in an exam point of view. The first most important one being disconnected pancreatic duct syndrome. So basically what is happening in this case is there is a necrotic collection which is sitting in the central part of the pancreas, right? And this necrotic collection in the center of the pancreas is having a connection with the pancreatic duct, meaning to tell there is necrosis in the pancreas, that is in the center part of the pancreas, which has disrupted the pancreatic duct, and there is a connection between the pancreatic duct and this necrotic collection. So, on an imaging, how will you tell that this is a disconnected pancreatic duct syndrome? So, you will see that as discussed, there is a necrotic collection in the center part of the pancreas. And this collection should be of a size more than 2 centimeters. You should have a distal pancreas which is normal. And then on an MRCP, you should be able to demonstrate a communication with the pancreatic duct, between the pseudocyst and the pancreatic duct, and the angle should be approximately 90 degree. If all three conditions are satisfied, only then you can label it as disconnected pancreatic duct syndrome. Clinically, how will you get a requisition? The requisition will be like the patient is coming to you with increase in abdominal girth even after drainage of the pancreatic collections, right? So, this is a very important thing as a radiologist that you need to identify this syndrome, because if you do not identify this, patient will have a continuous complaint. Patient will come to you with a continuous increase in abdominal girth. And as an interventional radiologist, the treatment for this is you need to put a stent along the pancreatic duct. So the treatment varies. That is why it is important as a radiologist to learn about this disconnected pancreatic duct syndrome. Coming to the next important uh, type of a disease, that is hemosuccus pancreatitis. Hemosuccus pancreatitis, first we look at an example here. We can see that there is a collection. You can see that there is a pseudoaneurysm because it is typically round, it is very tiny. But however, you can see there are multiple areas which are hyperdense. So, whenever you're seeing such a collection where you're seeing an aneurysm, where you're seeing hyperdense clots within, if you look at the pancreatic duct in this case scenario, you can see that there would be blood in the pancreatic duct as well. And if you do an endoscopy, you'll see that blood would be oozing out from the ampulla of Whiter. And this would be confirmatory to call it a hemosuccus pancreatitis, right? Again, this is important because patient will have GI bleed, patient will have a drop in hemoglobin. So you might be thinking this is just a tiny aneurysm which is sitting in a pseudocyst. Not necessarily. Always whenever you're seeing an aneurysm within a pseudocyst, look for the clots within the pseudocyst. If you're seeing clots with an aneurysm along with clots in the pancreatic duct, always raise a possibility of hemosuccus pancreatitis. The third one, there is something called as PPP syndrome. PPP syndrome is a triad of pancreatitis, paniculitis, and polyarthritis. This is just a normal Viva question which usually people ask once you answer all the basic questions. So just remember there is something called as PPP syndrome, which is a triad of pancreatitis, paniculitis, and polyarthritis. Finally, one of the complications which is important as a radiologist to know is pancreatic fistula. There are two most common fistulas. Fistulas can be formed between the collection and any of the bowel, between the pleura, between just the cutaneous tissue. But most commonly we see these two type of fistulas, that is pancreatico-colic fistula. You can see that this is a pancreatic collection, this is the descending colon, and there is a fistula between these two structures. And the second most commonly seen is pancreatico-pleural fistula, as we can see in this example, right? Now we look at approach to acute pancreatitis. Most of it we have already discussed. We'll just summarize it here as to how do we look at a case of acute pancreatitis from a radiologist perspective. Starting with an ultrasound. If the 2 out of 3 criteria is met, what do I mean by this? Patient has a clinical history of epigastric pain. Serum amylase lipase is raised, but it is not more than 3 times its normal. Then still we don't call it an acute pancreatitis, right? In such a case scenario, you'll start with ultrasound, and that time ultrasound is done to diagnose acute pancreatitis. What would you see on ultrasound? On an ultrasound, you will see that it is bulky pancreas. What is bulky? I've already defined. It is more than 3 centimeters in the head, more than 2 centimeters in the tail, with minimal peripancreatic fluid, or there would be fluid in the Morrison's pouch, or you will see just some amount of fat stranding. Fluid might or might not be there, but a presence of a bulky pancreas should raise a suspicion of acute pancreatitis, right? But however, if 2 out of 3 criteria is met, that is serum amylase lipase was more than 3 times its normal, then also you go ahead and do an ultrasound. Because why do we do in such a case scenario is that it is to rule out the complications of pancreatitis, that is you'll be looking for some collections, or look at the etiology. Are you able to find some gallstones or a CBD stone or something like that? Look at to look at the etiology and to rule out the complications. After ultrasound, next question arises is when do you do CT and what are the types of CT you would be doing? The most commonly done CT is single phase contrast enhanced CT venous phase at 70 seconds is considered the investigation of choice. And when do we do this is in case of a moderate to severe pancreatitis, on day 3 of symptoms, you do a first CT, and then you follow up on day 7 if there is a collection which is getting formed, right? And I've already discussed any patient more than 40 years coming to you with acute pancreatitis, always do a contrast enhanced CT to rule out pancreatic ductal adenocarcinoma. Then finally, we have a dual phase CT. I've already discussed whenever you're suspecting a vascular complication, go ahead and do a dual phase CT, right? Finally, MRI with MRCP. This also, I think most of it we've discussed. Whenever you're diagnosing an early pancreatitis, in an early pancreatitis, I've already told you, if it is negative on ultrasound, you do not find a pancreatitis on CT, go ahead and do an MR. MR is the most sensitive investigation. And then that too, a specifically T1 sequence where you'll see a loss of fat in it, right? And then I've already told you, in a child, to rule out anatomical variations, always and always do an MRI with an MRCP before sending the patient home. And in an adult, whenever you're suspecting disconnected pancreatic duct syndrome, go ahead and do an MRI with an MRCP. Now, we come to the last topic of acute pancreatitis, that is interventions in acute pancreatitis. We do both non-vascular interventions as well as vascular interventions. Coming to non-vascular interventions, we do CT guided percutaneous drainage because it's a retroperitoneal collection. Pancreas is a retroperitoneal organ, right? So all the collections are mostly retroperitoneal. So we would prefer going with a CT guided procedure over an ultrasound guided drainage. So CT guided percutaneous drainage, few important things we need to know is indications. Indications I've already told you. When all are we doing CT guided percutaneous drainage, as in world of necrosis, if an acute necrotic collection with a patient who is worsening, and in a pseudocyst which is infected, then we go ahead and do a CT guided percutaneous drainage. Coming to the contraindications, these are the routine contraindications when the platelet count is less than 50,000 and PTINR is more than 1.5. Coming to the instruments, a Malacot catheter is more preferred to be used when compared to pigtail. However, because of its easy availability and easy usage, most of the radiologists, we use pigtail catheters. How do we approach this pancreatic collection? There are various approaches, that is transhepatic approach, transgastric approach, transperitoneal approach, and then we have retroperitoneal approach. However, the left retroperitoneal approach is the most commonly used approach for draining a pancreatic collection. Now we look at the vascular interventions. Among the vascular interventions, the most commonly treated ones are pseudoaneurysm and contrast extravasation. And so, how do we treat pseudoaneurysm is, you can approach the pseudoaneurysm percutaneously or you can go via an endovascular route. If you are doing a percutaneous approach, we use thrombin, that is lipophilized thrombin. Directly we inject into the pseudoaneurysm and then we allow it to clot. Otherwise, you can even use glue plus lipidol into the pseudoaneurysm. We directly inject it percutaneously. If we are going via endovascular route, most commonly what we use is coil. So you can just do coiling of the sac of the pseudoaneurysm, or we can do something called as sandwich technique for the treatment of pseudoaneurysm. What do you mean by sandwich technique? For example, we'll imagine the direction of blood flow is this. So this is the proximal door, this is the distal door. We take a coil, first close the distal door, as we can see in this example. Then we even close the proximal door. Once you close the distal as well as proximal door, there is no more blood entering into this sac of the aneurysm. And hence, there will be slow flow, stasis, coagulation, right? So, there will be no more pseudoaneurysm. There will be no blood flow to the pseudoaneurysm as well. Hence, we have treated it. Other technique we can use is an anchor technique, where you hook a distal minor branch and then you continuously coil through the entire length of the artery. However, if the patient has a deranged PTINR, then you can't use coils, right? Because coil you are actually waiting for it to activate the fibrinolytic pathway and then you are waiting for it to clot in its own. So, if the PTNR is deranged, this clotting procedure is not happening and hence you have to use a glue in such case scenarios. So, always remember, whenever there is a deranged PTNR, you should use a glue instead of a coil. However, you have a wide necked aneurysm, that too in the proximal part of the artery, where you cannot completely block the artery because of the distal ischemia and necrosis of the distal organ. In such a case scenario, you go ahead and do a endovascular stent. So, guys, here we come to the end of acute pancreatitis. If you guys want us to take some other topic which is difficult for you guys, or you guys are finding some difficulties in understanding, simplifying the concepts, so you can just leave a comment in the comment box and we would be taking the next class on the suggested topic by you guys. Thank you.